Hi, this is Dr. Robert Brueck coming to you from Southwest Florida. I've been giving a lot of thought to trying to capsulize my 37 years of experience in sharing that with patients and prospective patients and people who are interested in trying to find out more about certain aspects of plastic surgery. I've been doing it for 37 years and I've thought about it, and in that 37 years I've gained a lot of experience, a lot of knowledge. And I think it's important to understand I don't have all the answers. Many times patients come in to see me and I might be the first doctor they see or the fourth or fifth doctor they see. And I said the good is that if you see 4 people, you've done your homework, but sometimes you walk out scratching your head when you've seen the 4th doctor and wondering, what do I do now? You see 4 people, you get 4 different opinions. And it's not to say that they're right, I'm wrong, or vice versa. It's just that there's such a variability when you're talking about various cosmetic procedures. And so what I'm going to do is do a series, I call it Musings of a Plastic Surgeon. And it's trying to give you some insight into my development as a plastic surgeon, how I've changed over the years, how I've taken the basic principles of plastic surgery that I learned in my residency in Chicago and have developed them over the years. Again, it's not to say I'm right, they're wrong, or vice versa. It's just to give you a prospective patient, and maybe that you're a prospective patient with another physician, to give you some idea and some education and some know-how and share a little bit of my 37 years of experience. Now, one of the general principles that I tell all patients when they come in to see me, my job as a plastic surgeon is to take what you give me and use my 37 years of experience to maximize your expectations. And I think it's important to understand, because I hear patients come in all the time, well, my girlfriend went to Dr. So-and-so, got a 600cc implant, that's what I want. Well, maybe your girlfriend had an anatomy that could handle a 600cc implant, but that's not always the case. So I always say to people, I have to look at you. Your chest has a certain dimension, a certain diameter. There's certain distensibilities. Some people have more soft tissue than others. So there are a lot of aspects that go into developing a game plan to maximize your expectations. And remember one thing, as a prospective patient, I can't change that. But what I can do is I can call upon my 37 years of experience to try and maximize your expectations. So it's not a right or wrong. And as I go into other particular cosmetic procedures and share my 37 years of experience and evolution as a plastic cosmetic surgeon, I think you'll see that come into play. But I'm going to start off today talking about evolution of breast augmentation, where I was many years ago, where I am today. Breast augmentation is without a doubt one of the top, either number 1 or number 2 in terms of cosmetic procedure. Started back in the 60s with Tom Cronin in Houston, Texas, when the first gel implant was developed. And there's been a cycle, an evolution of the type of material. I know many times early on in my career back in Chicago, many of the early implants had fixation patches. And the idea was, if I put that implant in a pocket, how is it going to stay there? Well, thought was, we'll put fixation patches that will cause it to adhere to the chest wall and hence make it so that it doesn't shift. We've come 360. No longer do they come with fixation patches. We found that that incited a lot of scar tissue. Many of those implants got extremely hard, got very encapsulated, so that's no longer the case. We don't do fixation patches. I think the first thing when you're considering a breast augmentation is the type of implant. Now, 98% of the time I will put in a silicone implant. Basically, there are 2 choices, silicone and saline. Saline is nothing more than a bag filled with water. Saline is salt water. And I just, over the years, again, those 37 years of experience, it's not a very aesthetically pleasing implant. And remember one thing, the less breast tissue you have, the more important silicone becomes. And I'm going to discuss later on in this video presentation a new idea. It's not my idea, so I'm not taking credit for it, but a new technique that I'm offering to many of my patients, and I think it's a home run, and that has to do with the idea of a composite aug, and I'll explain that later on. So getting back to the type of implant, so you have saline, you have silicone. Now, many times people want to know about a composite gel form, gummy bear implant, whatever. There are implants that are very firm. They're sort of like gummy bears, if you will. I generally do not use those. I haven't used them simply because of the fact that they're extremely expensive. Many of these preformed, gel-formed implants are very, very expensive, and they're very firm, and I personally don't like them, the anatomically shaped implants. There can be malposition, shifting of the implant, and so I just don't find a use for them. Now, there are some surgeons that will go ahead and utilize these types of implants routinely in their augmentations, and again, that's okay. I think what it boils down to is the surgeon should use what works best in his or her hands. So for the majority of my patients, I use gel implants that's cohesive. That is, if you were to take the implant that I use, cut it in half, you have two pieces. It just doesn't ooze out and leak out like implants that were maybe 20, 25 years ago. So gel definitely is my implant of choice. Now, a lot of times people will come in and I do a high profile, a medium, a low profile. Again, the majority of patients that I do a moderate high profile implant. I don't utilize high profile except in rare cases. There have been a lot of articles written about high profile implants, and a lot of people have had complications with them. They may be that they encapsulate earlier, they've had distortion, they've gone ahead and given unnatural shape to the breast, puts excessive pressure on the breast tissue, particularly in smokers. I always tell people with smoking, you got to be very, very careful about the choice and size of the implant, because you don't want to put undue pressure on the incision, because when people smoke, vessels constrict and tissues don't heal. And again, that's a deadly combination. So no smoking. I tell all my patients, quit 2 weeks before, a couple, 3 weeks after, to allow the tissues to heal. So the majority of time, I do a moderate high profile implant. Now, a lot of times the question is, what's the ideal size? A lot of times I answer a lot of questions on RealSelf, and many patients will email me questions about size. And I tell people at the end of the day, I can't put a gallon of milk into a quart container. So a lot of times the size will be dictated by the size of your chest. In other words, if you have a narrow chest, that limits the size of the implant that I can put in. Now, when I do a breast augmentation, I usually will go ahead and have 3 or 4 different size implants. So I'll put in maybe a 275, it looks good, a 300 looks good, 325, 350, no, I'll do 325. So if anything, I'll err on the side of a little too big rather than a little too small. Again, that 37 years of experience tells me that women adjust up easier than they adjust down. So I always try to maximize the size. So when I'm done, and somebody looks at my patient, they'll say, boy, does Betty have a cute figure. It doesn't scream breast aug or boob job. I want it to be a natural look, and one that when you put on a bathing suit or halter top or a blouse or whatever it is you're wearing, that you look natural and you look good. That to me is the look that I'm trying to get. So moderate high profile gel implants the majority of times, because I just think it gives a softer, more aesthetically pleasing result versus saline or high profile implants. I'd like to now talk a little bit about the incision. There are several incisions that you can use. Some people use axillary incision. I think that's the least favorite of anybody. I don't use it. Because if you have an axillary incision in your armpit and you get a bad scar, it's there for the world to see. The other incision is a periareolar incision. Now, I generally don't use that incision simply because the dirtiest part of the breast is the nipple. And so now I'm making an incision around the nipple-areolar complex. I just think that there's a greater chance of potential contamination of the implant, and also can affect the sensitivity of the nipple. So I generally don't like to use that incision. Now, if a patient comes in and it's a redo, in other words, they had implants put in 20, 25 years ago, I might use that incision if that's the one they've had. But as a rule, the majority of times I use an inframammary incision. And I think it gives us the best exposure, allows me to visualize the entire pocket. And many times during the course of the procedure, through that incision, I will do a technique known as intraoperative tissue expansion. In other words, I make the pocket, I slide a tissue expander in, I close it off, and then while the patient's asleep, I will stretch out the tissues on the breast. And what I found over the years, again, that 37 years of experience, it allows me to put in a slightly bigger implant. So if 325 was marginal, I might be able to put in a 350. So I use intraoperative tissue expansion to go ahead and try and, again, maximize the expectations of the patient. Now, the inframammary incision is the one that I use primarily, and I think the vast majority of plastic surgeons in this country will utilize that as their approach. I don't know of anybody that's doing the umbilical incision where they tunnel up and then they'll put in a saline implant. I've seen several of those. They look terrible, they look hideous. It's not where I want to be, and it's not where I want my patients to be. So I utilize the inframammary incision the vast majority of time. The next thing I'd like to talk about is, where do you put the implant? Where do you place it? Basically, there are two planes. One is above the muscle, one is below the muscle. Now, the majority of times I will put it above the muscle, depending upon the anatomy of the patient and what their body shape is and how much soft tissue they have. When most people come in, many times people have seen another plastic surgeon and he says, well, put it under the muscle. And many plastic surgeons put all of their implants under the muscle. I don't like to say putting all of anything at one time or another on top of or under the muscle. Again, it's based on the anatomy and the expectations of the patient. Now, if you put the implant under the muscle, and this is true in most cases, when patients come in to see me, I show them that the majority of the implant, 95% of the time, isn't even covered by the muscle. It's just that superior medial portion of the implant that is covered by the muscle. The majority of it is below, and it's not even covered by the muscle. So it really is not an issue. And again, that will vary from patient to patient based on their anatomy. Now, a lot of times women come in to see me that have what we call pseudotosis. In other words, it's like somebody let the air out of the balloon. The nipple is not below the inframammary fold, but it's like you have a breast and a nipple, and you let the air out of it and kind of deflates. We call that pseudotosis. I've seen many women for secondary augs that have had implants put in under those circumstances. They encapsulate. So the implant is riding high, and the breast tissue itself is hanging off of the implant. You get like a double bubble deformity. And so I think it's important to recognize that when somebody comes into my office for a consultation for a primary aug. So if they have enough soft tissue, I prefer going on top of the muscle. Now, in certain circumstances, people are very thin. You have the person who's 5'3", weighs 95 pounds, is skin on bone. Almost routinely, whether it's saline or silicone, I'll put it underneath the muscle. Because in that situation, I want to get as much soft tissue on top of the implant as I can so it looks more natural. And that's really the case all the time. So if somebody has a good soft tissue cuff, they don't have pseudotosis, I'll do a subglandular placement the majority of the time, and I think that is really the best. Now, as far as pre-op and post-op, the only thing I really recommend patients do is obviously don't take any anti-inflammatories like aspirin and ibuprofen a couple weeks before. Stop all supplements like people are taking, ginkgo biloba, fish oils, things of that. Stop all that. Take the normal medicines you normally take. If you have high blood pressure, heart medicines, you take those. Post-operatively, I try to keep it simple. Number one, I have patients bring a bra with them, and that's what they go home in. And when you go home the first 4 days, lay low, don't do anything. So you don't have this done on Friday and then Saturday morning get up and vacuum. You just lay low for 4 days. And I tell patients, take a little Ziploc bag with a little crushed ice and put it between your breasts. With one exception, if I'm doing autologous fat, then I tell them no ice, and I'll explain that when we talk about a composite aug. So after 4 or 5 days, let comfort be your guide. I usually let patients take a shower after a day or two. I generally have them start massaging the breast implant maybe a day or two after the surgery, and the idea is I want them to move the implant in the pocket to try and maintain a certain degree of softness and prevent severe encapsulation. It's important to understand that everybody gets encapsulation. There's no exception to the rule. Everybody who gets an implant gets a capsule. That's your body's normal response to a foreign body. So expect it. It will happen 100% of the time. The key, though, is to keep it soft. And I've found that in the hundreds of augs I've done over the years, women who massage on a regular basis. Now, what do I mean by that? I usually tell patients every day when you take a bath or shower, usually once or twice a day, you're in the shower, soap and water, massage your implant to try and keep it expanded, stretched out. Don't let it contract and get hard. Makes a big difference. So do that all the time. Real physical activity, golf, tennis, aerobics, weightlifting, things like that, 4 to 5 weeks. And after that period of time, you can go hang gliding, kickboxing, you can do whatever you want. So the first 4 or 5 days, nothing. Soft, sweet, lay low, watch TV, read a book, do whatever. After 5 days, let comfort be your guide. So for example, if you're 5 days post-op and you're brushing your hair, then what you can do is, if it's not sore, brush your hair. If it's sore, then shorten your stroke or put your hair in a ponytail until the soreness goes away. So listen, at the end of the day, listen to your body. If it's painful, it's probably not a good idea to do it. So lay low the first 4 days, comfort be your guide, unleash exercising, bike climbing, golf, tennis, 5 weeks or so, and you're good to go. Now, one of the things I want to talk about, and I think this is a tremendous advantage for breast surgeons today, and that has the idea of fat grafting to the breast. Now, what I call it is a composite aug. Now, what I've been doing, and I've been doing this now for several months, and I've done several cases, both it's a primary aug, a redo it, and in some cases, actually taking implants out in their entirety and replacing them with nothing but a patient's own fat. So a composite aug is harvesting fat from a patient's body, stomach, flanks, inner thighs, wherever they have extra fat, and utilizing that soft tissue, i.e. their fat, to create more cleavage and more fullness. The nice thing about fat is I can place it where I think it needs to go, where the patient wants it. So we call that a composite aug. So for example, I might put in a 300 cc implant, and then I will put 100, 150, 200 cc's of the patient's own fat superiorly and medially to give nice fullness to the breast. And it's a wonderful, wonderful look. Now, it's important to understand we're grafting fat from one part of the body to another part. Most of that fat will take, 40 to 60% takes. What fat doesn't take, your body breaks it down, absorbs it, not a problem. It's your tissue, so we're using your tissue to rebuild your area, i.e. the breast. It's a great, great technique. Now, the preface to that is the patient has to have areas of fat that we can utilize and suction. But I also call it a two for one. In other words, you're getting rid of fat from one area of the body where you don't want it, and you're putting it in an area of the body where you do want it. So it's a home run in my opinion. And patients that have it really do love it. I remember one lady I did recently, she was in her 60s, she was still working full time, she's a stewardess for American Airlines, and she had had implants in for about 25 years. And they were hard, they were tender, they were sore. She said, you know, Dr. Brueck, I want to get rid of them. I don't want them anymore. Just take them out. And I said to her, I said, well, if I do that part, you got to understand one thing. It's going to be very deflating, no pun intended. And you may not like what you're going to look like once we do that. I said, have you ever thought about taking the implants out and maybe restoring some of the lost volume with your own fat? So I showed her abdomen and her lateral flank. And I said, we can suction fat from those areas and put it into your breast. And with amazement, she said, you can do that? I said, sure, why not? So that's what we ended up doing. So we took out the implants and we went ahead and we harvested fat from her stomach and her flanks, and we put the fat in her breast. And amazingly enough, she's slightly smaller, but she has a soft breast now. It's not totally deflated. She's happy. She doesn't have the pain anymore or the hardness or anything like that. So it's a wonderful thing that we can offer patients. And I offer it to some of my patients with primary augs. So somebody will come in and they maybe don't have a lot of soft tissue on their chest. And they, for example, have very thin tissues here. Because you always got to be careful when you're making that pocket that you don't go too far medial and you release that skin bridge and then get symastia or the uniboob. So what I do in that situation is I put the implant in, and then I harvest fat, and I can create cleavage by using their own fat without running the risk of detaching that skin bridge and creating a problem that's extremely difficult to go ahead and correct. So composite augs are a nice way to go to improve the aesthetics and the look of a breast augmentation. And again, you can use it with saline or silicone. I usually use the silicone implant. So what I normally do is I make my pocket. I'll put my silicone sizer in once I've decided the size. And then while the sizer's in place, I harvest the fat, and then I prepare the fat. And a lot of times I'll put platelet-rich plasma. In other words, I draw off a patient's blood, get what we call PRP, platelet-rich plasma. And in the platelet-rich plasma are alpha granulocytes, which have about 18, 19 polypeptides to enhance the survival of the fat and regenerating skin. It's a great technique. So I take the PRP, mix it with the patient's fat, then with this implant in place, the sizer, I add the fat. Then I take it out, one last check, irrigate with antibacterial solution, put it in the implant, and close. So it's a neat technique. Now, when I do fat grafting, I tell patients, do not under any circumstances put ice there. Because what I want to do is promote blood flow to the area to enhance the taking of the fat. So by putting ice there, vessels constrict, you don't get as much blood flow, consequently it can impair the ability of the fat to take. And of course, without question, no smoking. Because when you smoke, vessels constrict, you don't get blood flow, the fat doesn't take. So it's very, very important that patients, and I tell this in my facelift patients, breast aug patients, tummy tuck patients, whatever, no smoking, because it only impairs and prevents us from getting the best result. So again, these are just some comments of mine that I've developed over the years, things that I do now today that I didn't do 20 and 25, 30, 35 years ago. And I always like to grow. I always like to add new techniques. And my philosophy is I want to make sure the techniques I add are going to enrich the results that I can give to my patients. So I hope you found this interesting. We're going to do some more segments on musings of a plastic surgeon. The one I'll probably do next is on facial aesthetics, facial cosmetic surgery. So I want to say thank you for bearing with me and watching, and I hope you found this interesting. And if you want, you can go to my website, Beauty by Brueck. Some of these patients' pictures are there. You can request a consultation. You can do a virtual online consultation with Zwivel. All my cosmetic consultations are free, so feel free to come in. You can call me at 239-244-2329. 239-244-2329. I also have an office in Punta Gorda, and I also have one in Cape Coral. And I want to wish you and your family the richest of God's blessings. And again, thank you for your time and interest in this video.